So it's my privilege to welcome the U.S. Secretary of Health and Human Services, Sylvia Mathews Burwell, to this Secretary one-on-one session. At HHS, Secretary Burwell leads more than 77,000 employees in work that literally touches the lives of every American at every age, from every background, and in every corner of our country. She's known for being an adept manager of complex and sometimes controversial issues, and for her commitment to making a difference in whatever assignment she takes on. These assignments have been many. They've included leading President Obama's Office of Management and Budget, serving as president of two large, well-known foundations that you may have heard of, the Walmart Foundation and the Bill and Melinda Gates Foundation, and taking on multiple roles in the Clinton administration. Her educational background is superb. She has degrees from Harvard University and from Oxford University, where she was a Rhodes Scholar. During her tenure at HHS, the Secretary has been a champion of medical innovation, which is why she's here today. And in this session, we'll share her perspective on how government and industry can work together to advance new treatments and cures. Welcome, Madam Secretary.
By the way. Now, did you hear what George said about the Greek flag?
Oh, no.
Oh, yeah, he said that was for him. George, would you like to beg to differ with the Madam Secretary?
Yes, right here. It's true.
And once again, I'd love to encourage.
Second generation.
There
All
we
four
go.
of my grandparents.
Any other Greeks in the crowd here? Break some plates.
Actually,
It's okay. We're a friendly crowd. Toss them across the room. The Secretary is known to be very transparent, fun, and open-minded.
And Greek.
Yeah. Welcome.
Thank you.
So,
you.
I'll tell you what, I remember at your, and by the way, questions please. I've got the iPad up here, so feel free. I'm monitoring as we go. I remember your swearing-in ceremony, and President Obama was talking about how you're very well known to take on tough challenges. So, as you're accepting this post as the Secretary of Health and Human Services, I mean, you couldn't have stepped into a tougher time, Madam Secretary, from Obamacare to the Ebola firestorm. So I guess, why the heck would you want to take such a controversial post? Why don't we start there?
Well, in terms of, that is a little bit true. I will admit that when I got to the department, and first there were 57,000 unaccompanied children that were in the care of HHS. Things kept going. I went to the deputy who'd been there since the beginning of the Obama administration, and I said, Bill, can you help me? He said, don't worry. Every secretary has one new thing that, is the firestorm they have to pass through, unaccompanied children. And then Ebola and a little bit of smallpox at NIH after 50 years. And I went back to Bill and he said, don't worry, they come in threes. Then, after a series more of lab incidents and other things, I went back to him and he said, don't worry, they come in 33s. And that really has been the story of my time. But in terms of why, and it's actually part of why I'm here, is because I've been fortunate to have the opportunity to work in places, whether that was at the Gates Foundation or at the Walmart Foundation or other places and in the Clinton administration, where you work to deliver impact. And I'm lucky because I've worked at organizations where you get to do it at scale. And in terms of the issue that we're talking about here and how it actually, I believe, works together with the issue of the Affordable Care Act and changing the way we deliver quality, affordability, and access to healthcare in our nation, it is a critical time and a unique time where I believe we can bring together fundamental change by working government and industry and the consumer in partnership to change things. And so that is why when the president asked, I said yes, though he didn't tell me that all those court cases would change to my name.
Yes.
That he did not mention.
Which I believe it was just this week or last week, there you were having to testify. Yeah. Well, it's interesting because you've never been a politician, which I'm hoping is going to be the beauty of this interview, because you're going to be very honest and transparent and straightforward. But, you know, I remember John McCain saying, wow, we're really glad she took this job, but boy, is it thankless. And then I remember Orrin Hatch saying, yeah, we're really glad she took this job, but my gosh, it's a terrible job. And I just remember thinking, wow, did she realize what, and you did realize what you were stepping into. And a big part of it was because you said you believed in Obamacare and you supported it. Tell us why, and tell us where we stand now and why you do fully believe in this.
So at the root of the legislation are the concepts of affordability, access, and quality. And these are three concepts that I firmly believe in. And my exposure to the problems that are created when you don't have those things, and where we were as a nation. So, you know, I came from, you know, I'd been in the private sector. And when you see the issues of what the costs were, what was happening in terms of cost, and you look at how our costs were aligning with quality, that's a very big issue. When you look as a nation in terms of our uninsured rate, you know, as you know, the nation that we are, and the question of where we are with regard to that. And having worked at OMB, I had the opportunity, when I was at OMB and I was the deputy director, we balanced the budget for the United States of America. So deficit issues are issues that I am familiar with, care about deeply, and the questions of these costs and what they mean to the federal budget. So all of those things, I felt we had a real situation that was a problem. And I believed we could do better. If you look back over the arc of the history of this issue of the quality, affordability, and access for a nation, we've been working on it for 100 years. You can go back to Teddy Roosevelt and find the quotations. And it goes president after president, Republican and Democrat. Richard Nixon, Jimmy Carter, you can go. And so the opportunity to work on what I believe we can have fundamental change. And I believe we've seen some of that change in terms of the issue of access. So about 16.4 million fewer people are uninsured in our country since the passage of the Act. Some of that because the economy's improving, and hopefully they have employer-based care, but the vast majority of that through changes that have occurred. The issues of quality. Can we make more progress and do better there? Yes, but are we starting to see a little bit of that? You see some of it in things that people forget are issues of quality. The fact that you can no longer not be insured because of a pre-existing condition, that's quality. The fact that as a woman, I'm no longer discriminated against or can be discriminated against in terms of pricing for my health care, that's quality. Reduction in readmissions, reduction in harms, it's quality. Then the affordability issue, which is one of the ones I was touching on that I feel was a large problem. What we've seen across the board in terms of the increase in per capita health care spending in our nation in 11, 12, and 13, we've seen the lowest in decades. In terms of, if one looks at the trajectory of Medicare spending before the act was passed and where we are now, $316 billion with a B dollars less. And so, and if you look in the marketplace, 8 out of 10 folks can find with the subsidies care that are premiums $100 less. So that's why, that's where it's happening. That's why I came to it.
Question coming from the audience, where do you think the ACA has worked and also failed?
So in terms of where it's worked, I think I've articulated a number of the places in terms of the places that it's worked. The place where I think we need to give it more energy, and that's one of the things. I think if we can all come together in common ground, a concept I think that's important. I just came from doing an event with the governor here on opioids and heroin. And controlling those issues, because I believe there are spaces for common ground. This is a space in the area of the Affordable Care Act that I believe there is common ground and where we can do better to get to the point of that question. And that is in making sure that we have better care and spend our dollars more wisely. Delivery system reform. The idea that we have got to shift from a system where we pay for volume to one where we pay for value. And there are leaders leaders that are a part of the program in terms of that. And that's the place where I think we need to put energy and effort, and why one of the first things that I did was focus on this, get us to a 3-part strategy. An old McKinsey hand, so do things in 3s generally speaking. And also because I really, right now I only have a year and 9 months. So I got to work against a targeted group of things. Those three things
You
are...
have a lot to do, by the way, in a year and 9 months.
I do. The three things that this strategy that I believe we really need to put our shoulders against: one, changing payment systems, how we pay for care. Number two, changing the way we provide care, and that's about the integrated care system. It's also something we'll touch on today with precision medicine. I believe that's about that too. And three, the issue of how we use data and information, both the providers as well as the patients in terms of that. On number one, we did something that hasn't really been done. Announce that we would move Medicare payments. 50% of all Medicare payments by 2018 would be in an alternative payment system, a value-based system instead of volume. And because I know I won't be around then, set the goal for 2016 to be 30%.
Let's talk more about Precision Medicine Initiative. There were a lot of questions about that, and that was something you definitely said you wanted to talk more about. You just mentioned it. And I will also get to the other initiative that you're focused on with regard to prescription drug use. Precision Medicine Initiative, if I'm correct, we go back to the State of the Union, President Obama talked about $215 million, correct?
That's correct.
All right, so let me start with, where is that money going to be spent? How is that going to be allocated? And what's it going to do?
So in terms of, let's start with what's it going to do and then go to the allocation. In terms of what it's going to do is try and build on the progress that many people in this room are already doing in the private sector and in academic institutions and other places, in terms of moving us to a place where individualized medicine based on genetic as well as environmental and other information about an individual, their lifestyle, can come together in a way that we can do better, both in terms of health care when people have incidences or are sick, and do better in prevention. And so that's the underlying concept of what we're trying to do, and to move that science forward even more quickly and play the role that we as the federal government should play as partners, supporting and indicating where we think we should go with our dollars, and also our regulation. That gets to some of where the money will be spent. So the funding will be spent in 4 places. With the largest amount of the money going to NIH, and that's in 2 different places in NIH. One is at NCI, the National Cancer Institute, because we put that money there because as we think about short-term gains and long-term gains, cancer is the place where we have seen in our research and the work that we're doing some of the most progress in this space. And whether it's the patient I met when I was out in California visiting with folks in the Bay Area about this topic, and a woman who had stage 4 breast cancer and chemo didn't work, and then moved to precision medicine approaches, and now it is 2 years later and she is cancer-free. And so we see progress there. So it's about doing more trials, making sure that resistance doesn't develop, and making sure that we have databases that can move the information to increase knowledge more broadly. The second area where the money will go is NIH, in terms of creating a cohort, and a cohort of 1 million. And the idea behind the cohort is to create enough people, data, and information that we can move through understanding things more quickly. Third area, FDA. The regulatory issues around this, we need to advance our ability to regulate in a space that is different. And we know that. We want to invest in it now at the beginning in partnership as we design the cohort and as we see things moving through NCI. And finally, the Office of the National Coordinator. And probably many people in this room know what that is, but that is the place where we do our electronic health records. And so making sure that you have the ability to maintain privacy in terms of the cohort and other issues, but also that we can move records in ways that the information can be used in a meaningful way.
You mentioned trials. I just took note of that. Okay, prevention trials. We're talking, those take 5 to 10 years. So is our patent law up to date? And it doesn't seem that the patents are, they're not made for this specifically, if you look at the timeline, right? And what's involved with prevention trials.
So I think as we move to the next decades, and whether it's issues of biosimilars or the issues that we're talking about in terms of precision medicine, we're going to have to figure out ways to regulate and define. And that's a part of what the money is going towards. As we go through figuring out where are the places where we need changes or different approaches. When is something exactly like something? When is it not? What does it mean to provide the guidance? And certainly we've recently approved some things in the biosimilar space. Last year, We approved more drugs, new drugs than we had in 20 years. And right now, in terms of the FDA and other countries, in terms of first approval for places, I think the numbers are, in terms of Japan and over 50 days, but it goes up to 140 when you get to the European. So we need to continue to evolve it, but it's going to have to be done on the specifics of what the products are and how we think about these safety issues. Because at the same time, we all want speed, and we want due speed. If I say the word scopes, I'm sure there's someone in this room who has either been involved with, or certainly everybody in this room has read about the issues around scopes and the questions of safety. And so whenever there are the issues of safety, and whether that's in Bluebell's ice cream or the scopes, making sure that we're balancing that speed with safety is a very important role that we have to play.
Interesting question came through. It kind of takes us off a little bit, but then we are talking about drugs. So if you don't mind, I thought this was an interesting question and probably impacts a lot of the folks in this room. After 20 years of training, MD, PhD, residency, I'll be making less in salary than a salesperson working for Big Pharma. What does that tell us with regard to profit margins of pharma companies?
I'd probably turn that question to you all.
Would every company CEO please stand up and tell us?
Turn that question to you all. I think when I think about physicians and physicians in practice and think about the work that we do each day, that's a lot of what the delivery system reform is about, is getting to a place where physicians can practice in the way they want to practice, what they want to do, why they went into medicine in the first place. And I understand, because I meet with all the provider groups and providers, and so I understand the struggles with electronic health records, and I understand as we're moving through the system. But what we need to do, and having been to places, and whether that's Montefiore in the Bronx or other places where changes are occurring in terms of how that provider can practice in a way that they are able to see and treat their patients and be with their patients the way, that is about an integrated health system, a system that has home health, a system that allows people to operate at the top of their license and then affords you, wherever you are in that licensure, to do what you went into your space to do. So I think we need to make the changes in the system. That doesn't exactly get to the money issue, but it all does relate. And I think those are the important things. And because we as a payer are such a large payer, whether you say we're $1 in $3 or $1 in $2, depending on how you count our relationship with Medicaid and the state dollars, we need to move that payment system so you are getting quality related, and then as physicians practicing, you hopefully will move the dial some on that.
Here's a question too I think is appropriate just because of your background dealing with issues of poverty. Even Michelle Obama, I mean your boss's wife, really big on issues of obesity and healthy food.
Yes.
The question is, how are we going to handle the public policy issue that eating healthy is 5 times more expensive than eating things that are less healthy?
So actually, I think everyone probably thinks about my background in terms of Gates with regard to this question, but you should probably think about it in terms of Walmart. So when I was at Walmart, Walmart committed to taking $1 billion out of the prices of fresh fruits and vegetables. Created a market basket that was a defined market basket that would compare price over a regular period of time with the rest of the marketplace in terms of the cost of basic fresh fruits and vegetables. And so this issue of cost is a very real one. It's not the only one. Hunger, Walmart gave $1 billion to Hunger when you count the food contributions, the largest provider of food in the nation. And so this was an issue we spent a tremendous amount of time on philanthropically and from the business, because it was the business that was providing the food. We can change price, and that is important. You have to change access as well, the concept of a food desert. And so making sure that you're getting that access, that price, and then there's a third critical path issue, that even when you bring those things in line, and that's use and ability to use. So if you're a mom or a dad, and you're going into grocery shop between work and going home, average time, about 20 minutes in the store, because you're just getting it to get home and get it done. And then the question of, do you know how to use it? Have you cooked with these things before? I mean, how do you think about that? And so there are a number of elements to this critical problem, and organizations like Share Our Strength have training programs, but price is a critical path issue, and I think suppliers and others need to work on the price, but access is, and then education and use are the other issues to get people to a different place with regard to this. And the First Lady's efforts in terms of Let's Move and that sort of thing, in terms of speeding us on education, honoring the healthy eating, using the children to educate. In my development space and the work that I've done in development, hand washing, sanitation in the developing world, huge issue. I'm sure we don't need to go into why that is a big issue, but it is one of the most important things with regard to health. The best place to make progress, children. You get the children to do the hand washing and then it spreads through. And similarly here in terms of educating our children about this healthy eating.
I just noticed something, and it made me think of the time that I see where this comes from. You used to work with Bill Clinton. Did you notice she does this?
It is.
She's got the Bill
There's
Clinton.
a third way.
She's got the thumb.
There's a third way.
I kept
I'm
noticing
sure this
it.
is being taped and he'll see me do that. Oh well. Oh,
I know
well.
he's very proud of your success, by the way. He saw big things for you, and he's not surprised. Well, let's stick to your 3-point strategy here. This question coming from the audience: how do global healthcare trends, India, China, influence your 3-point strategy?
With regard to the issues of the affordable care, quality, affordability, and access, is that what they're referring to?
I'm assuming that's what they're. I'm assuming if that person wants to say yes, no, shout it out. Get yes. Okay. Yes.
Okay. So I think that the 3 issues of affordability, access, and quality are, it's the same issue around the world and the same issues that I had the opportunity to work on at Gates, just with a very different population in terms of when you're thinking about the developing world. And it's interesting the list of countries that people put on the list because India and China are both places that I would differentiate in certain ways from the continent of Africa. While India has more poor people than the entire continent of Africa, it also has something else, which I'm sure there may be representatives in this room of Indian industry in terms of the technology and the tools and creating the tools that serve in the health space. And so both India and China are contributors to the solution space, even though they have elements of the problem, while the continent of Africa isn't as much. But I think you have to focus on the same things in terms of quality, affordability, and access. And affordability just becomes such a dominant concept when you're trying to get distribution into these places and the distribution mechanisms. I mean, why do we still have polio? We know how to fix that one. We do. And we still have it. And just think about the cost as a world, because you're still doing it here in our country. And so these questions of focusing on what are the fundamental levers, and technology is a very important lever. I came from an organization, I think everybody knows, the Bill and Melinda Gates Foundation really does believe that tools and technology, vaccines are such an important cost-saving way to make progress on these diseases, but distribution is the other part to get to access and affordability.
You keep mentioning the Gates, and boy, are they generous with their money. And when we think of what every American wants to know, it's how are we going to have higher quality of care with government and private sectors working together?
Well, I think that one of the things that we need to do, it is about that working together in terms of how we can do it. We, the government, are a payer and we're a regulator. And so one of the things that I believe in doing delivery system reform is in the places where we as a government need to lead, and that is as a payer saying what we'll do, as a regulator indicating where we're going in terms of the types of changes that we'll be doing, and in helping set standards, and that's the Office of the National Coordinator with regard to how do we get to a place where this information is interoperable. That's our role. At the same time, I believe that it's important to embrace partnership and work together, because we're a payer, but there are a lot of private payers. So setting the standards by which we're going to judge quality together in an aligned way is going to be so much easier and better for providers. And that's why I mentioned the announcement of our commitment to move Medicare payments. The part that I didn't mention that was announced is something we call the Learning Action Network. And at first I was, should we do a network? how's that going to work? But it has become, and it became clear before, and we announced it, and now having private sector partners at the table, including consumers, be a part of the design, understanding the unintended consequences. You can cause consolidation as we try and move through this. What does it mean for the consumer? What does it mean for the insurer? How are the providers? And having everyone at the table, having that conversation is what I think will speed us through transition, get us to a higher quality result in that transition, and reduce the negative unintended consequences, of which we know there will be some.
Another question, short and sweet, pros and cons of single payer system.
You know, we are in the system that we are in, and our system is a market-based system. And what I believe right now we all need to do is focus on the way that we maximize for care, quality, affordability, and access in the system we're in. It's interesting that the marketplace, which, what we refer to the individual market and the federal marketplace and the state-based marketplace. So J.D. Power last week came out with a survey. And what the survey showed is that people that came through the marketplace were more satisfied with their coverage than people in employer-based care. And part of that is the market at work, because this is a group of people that are actually using a marketplace to shop. When you go and you look at what happened in this open enrollment, so in this open enrollment, we have about 11.7 million people came in or re-enrolled. The percentage of people who were previously enrolled and came back in and either updated their information or shopped was over 50%. I know everybody in this room, because there are a bunch of CEOs, you all have employer-based care. And what percentage of your employees actually come back in every year? Nowhere near 50%. And so this idea of, the way I answer that question is, we have the system we have. And it is a system that I believe we can get very high quality results, and that's what we're working hard to do. And the question is how do you move through and do that?
Okay, here's your first OMB and HHS question. What would it take to get healthcare spending under 10% of the GDP? Will it happen by 2020, 10 years after ACA?
I will not answer that on the fly, because that is a highly analytical and numeric-based question. And I could do parts of it, but the part that I probably am not familiar enough is we have an issue that we all just, I think, have to understand in terms of healthcare costs, and that's the fact that it's called the baby boom and echo. So even when we get per capita costs to the level that I'm talking about, you notice every time I talk about costs, I'm talking about per capita, because that's what you have an ability to control. We don't control the fact that a number of people in this room are going to be over 65, and it's a larger number than we as a nation have known because of the baby boom. And so how to get to the analytics of that question, I'd want to stop on and go through, because a big piece that's going to drive this is the total number of people in the system, and that's the baby boom, and because we do extend life, because we are living longer. And so those two things, even if we get the cost under control, what we need to do is keep growing the economy and keep working on those per capita costs.
Well, here's a question for you. What do you need from manufacturers to succeed in your vision?
One thing that I always need is feedback, and clear feedback that tells us where we're getting it right and where we're getting it wrong. That is probably, it is a meta thing that we need, but it is the most important thing that will help us do our job better. With regard to that, their connection to, as they're doing their work, as manufacturers do their work, making sure that they are so deeply connected to the actual consumer. And I mean that because I think they are deeply connected to their primary customer, the provider. But I believe we are evolving to a system, 10, 20 years from now, we're going to be in a healthcare system where at the root of it is the individual and the customer. And this gets back to the other question. That's how a market works. A market works when the actual customer can relate value that they're getting to price. And that's where we're going to move, and we're moving to that with precision medicine and individualized care. It is about that consumer and customer, so getting that proximity to them, what they need, what they want, how they will think about price is, I believe, eventually where we're going to be.
Looks like we have time for one more question. I promised you we would get back to your other initiative focusing on prescription drug use. And this question, you bet, coming from the audience, and then I'd love for you to close us out with any final thoughts if we didn't touch on anything you wanted to hammer home. How do we control opiate prescription abuse without negatively impacting legitimate pain prescriptions by doctors who are already under-treating due to fear of government scrutiny, even prosecution?
So I would be interested in the examples of the people who are under-prescribing because of fear of prosecution. Would love to know about them and hear about them. Having just been with Blue Cross Blue Shield and this morning, who has a great program that they do in this region, I think their numbers of anyone who has even pushed back at all, even a consumer that has pushed back on inability to access, is very, very, very small. And in a world where 250 million prescriptions for opioids were written in 2013. And that was 2013, and oh, by the way, the governor just announced in the state that we're in today that his deaths have gone up in 2014. So let's assume the numbers are going up. When there are 250, that's every adult in America. And this is, story after story about, even today, the Secretary of Health for this state talked about how she got 60 Percocet for an outpatient procedure that she probably would have 3 days of pain for. 60. And so the question of what do we do? So the idea that the pendulum should swing, pain and treatment of pain is extremely important. Cancer patients, people with permanent pain, this is very, very important. And we need to make sure that we protect that.
But
and
abuse
part of the ways
is such a huge
issue. Huge issue. The number of deaths. I just think the recognition of how many people and where it is in our population. This is not socioeconomically bound anymore. This is not just the poor in our country, and it's not geographically limited to rural America, where I'm from, in West Virginia, where the problems are acute. It is all over the nation. It is in the entire state of Massachusetts. It is in neighborhoods. And that I will praise the governor because he is putting out the numbers on a local basis. So you can see where the problems are in the state and work to treat them. And I would just, on this issue, would just say 3 fundamental things. Prescribing, and in working on prescribing, we've got to work on making sure we're protecting physicians and customers' ability who need, patients' ability who need the product. Second, access to naloxone, preventing the deaths. It works. We don't have enough access to it. It is what prevents so many of the deaths. And the third is medicated assisted treatment together with appropriate support to the medication in terms of therapy and other things that people may need. So a big problem here that we have to be careful, but I think we need to go very hard at this problem as a nation.
Final thoughts?
Just thank you. Thank you. This is a group of people. We didn't spend as much time, on the precision medicine, on the innovation. This, from where I sit, and this is my old OMB hat and my HHS hat, I still am part of the economic team. And that's, historically what I'd always been a part of in my service in government. And I'm happy about that. And I just believe in the issues of innovation and what that means to drive the health of the economy as well as the results that we get. So I was thrilled about what this is about, why people are here, and I believe it is fundamental to the changes that we can make in our system. And I know it's hard, and it isn't simple, and there are, like anything, there are upsides and downsides, but I believe the more that we interact, communicate, and partner, the better we'll be, which is why that point of input and feedback, we welcome it. Because, at least my experience, whether it's in the private sector or the public sector, 2 ears, 1 mouth, generally the ratio is there for a reason.